So the Dreal technology, as Bob said, is really the mastermind of Yossi Weitzman and also Eli Ashkenazi out there in Israel. And it's really about providing us with better tools to cut bone. I know that seems like a very simplistic statement, but really, I think the best technologies are ones that actually fulfill a surgical need that we've had for a long time, not creating a new artificial space, but fulfilling a need to actually help us solve problems that we've not otherwise been able to get past with existing technologies. And so because of that, the Dreal technology and the Dreal handpieces, by very definition, are tools that we have to use with our hands to cut bone with as a supplement to our existing drill technologies and shaver technologies. And because that, one of the first nuances of the Dreal type device is that you have to, I know it sounds silly, but you literally have to learn how to hold it, like a tennis racket or a golf club or a weapon of any type. How you hold it is probably as important. So the key is that you want to, the device, as you know, these devices snap onto existing drill motors. And because of that, a really simple statement is that you want to hold the device and not up on the drill shaft, the motor of the shaft. And you can see that graphically demonstrated here, where you can hold the handpiece either in a forward or you can hold it in a kind of a backward grip. But either way, you want to hold this piece. Also, it's very important as a nuance to have you or your scrub tech make sure that the motor is very solidly engaged here. And sometimes you can even put stereo strips or whatever else to make sure that it doesn't come apart. And those are all useful things. And having the adapter all rigidly locked together is a very important thing. Holding the handpiece is one of the obvious, but yet sometimes overlooked things. Here you can see us on the left side of the screen using a forward grip, kind of typical thing where we're typically working away from us. And then for contralateral approaches and things like that, we can often go to a reverse grip. So here, the forward grip technique working, and then the reverse grip for the ipsilateral approach, where we simply take the device and turn it backwards. So we're working towards ourselves at this point in time, often, for example, the ipsilateral approach. So either way, what you want to do is always make sure that you're holding the handpiece. And also that one of the also little subtle nuance in terms of ergonomics during the procedure is that you can see in the video, again, the handpiece, and then in this picture, a Black Max on-spot motor behind it. So there's the adapter, silver section, and the black piece. And so inevitably, and then of course there's the cable, the drive element coming out. So inevitably there's a bit of height to the stack up, even with the relatively short Dreal handpiece. And because of that, you have to make sure that you can ergonomically see, simply put. And so here you can see the microscope clearance is such that you've optimized it for every microscope, and every surgeon who has different height, so to speak, above the body. You're going to have to find the sweet spot so you can work both in a forward and backwards fashion while looking through a microscope, if you use a microscope. And if you work through a tube, you certainly need a microscope or an endoscope. But whatever it is, you have to make sure that you've optimized that working space between there, in addition to your grip. And also, obviously, that you can see around your own hand to get down. That's where the bayoneted tips are sometimes more helpful. So these are all the little ergonomic things that are part of the learning curve that you'll overcome fairly quickly, fairly rapidly. But it's just something you have to kind of think about even before the procedures start, to make sure that that's all optimized and doesn't cause you a lot of bumping and obstacles as the procedure goes forward. And those are things that your reps and things like that can also help remind you of as you get started. So again, it's a powerful powered tool. And you know, you have to realize that, because just like all powered tools, there's unique aspects of torque, the feeling of how the motor ramps up, irrigation flow, all these things, you have to sort of optimize that and get used to that as you're going forward. For those of you who have ever worked with irrigating drills, you know, there's a different optimal speed of irrigation. Also in terms of cutting, do you run it at full power with the thing down or half power? It gives you a different feeling of torque, or run on bone, soft bone, hard bone, you need a different amount of torque. So these are all things, again, a part of that learning curve that come out and go forward. So these are all things that you'll get in time, but just, you know, give yourself a little patience. So when you're working with soft bony tissue, you can see you can use the the Dreal for the bone and the Carevature Medical Dreal for the soft tissue. The Dreal shavers are not like all shavers, not really optimized to cut like ligament and flayed synovial cartilage. So you should really use Carecins to remove that part because it can grip and bite soft tissue a lot better. So a good way is to keep the ligamentum flavum or to keep the synovial facet cartilage on there, drill simply underneath it, remove the bone, and then the remaining soft tissue, the flavum, synovial cartilage, ligamentum, whatever, can be removed with a biting tool, which is optimized. Just remember that, unfortunately, just like all tools, it's not, these tools are not optimized, as you can see in the video here, for cutting soft tissue. And here you can see us working out the lateral aspect of foramen, skeletonizing the bone down, and then coming in and protecting, and then coming in with a curette, working off the soft tissue. You can use a Carecin, and then you notice that we also have, as usual, the standard technique, still went ahead and protected the dura. Here's the Carecin coming in to bite off the remaining soft tissue. But during the drilling process, it's not a bad idea to still protect the underlying edge of the dura with a cottonoid, a thin cottonoid if you want to. But either way, all the standard, cautions and precautions are very important. Here you can see the cottonoid in place as we're drilling again. Apologize. So really what we were saying earlier on the previous slide was that there's a variety of ways to kind of optimize and work the thing. And then again, there's no, as the thing spins, it's still a spinning object. So sometimes with the water and the flow, we can unfortunately get some ingress of the dura and things like that. So having a cottonoid to keep an additional layer of separation, or a woodson or something to physically maintain a hard barrier between often thin dura and the spinning Dreal drill, even though it's shielded and it is safer, is still a good idea. Coming back a step, avoid what we call running of the drill on the bone. You want to get a feel, just like your accelerator on a car as it grips the road. When you work with drills, if you run the drill at too low power, sometimes it can just slide on the bone. On the other hand, if you put too much force on it, it will bind up. So a good technique is, as you see here in this graphic demonstration, as you engage the bone halfway, you start to push the switch foot halfway, and that starts the drill spinning. So now it's spinning and it's overcome its coefficient of static friction. Then you engage the bone and start to ramp up, and you hold it firmly, and you still apply minimal force because you don't want to stop the drill. You don't want to bind the cutting, spinning edge on the bone itself. And then you gradually increase the speed, so increase the cutting speed as you increase the pressure, and then you advance in that fashion through the bone. And that's actually how you go about the thing. And that's just a technique of preventing run on the Dreal object running on the bone, and also it keeps you from jamming it. So that subtle play of the switch switch, just like, again, the subtle foot play of an accelerator in a car to cornering, turning, and accelerating, is the same as true as when you're cutting the bone. And because of the bend of a lot of the Dreal tips, this consideration becomes even more paramount. So there you can see, I think someone's off mute, but there you can see the cotton patty on to protect the underlying dura. And then the edge of the nerve retractor or suction tip, as I said, can also be used to help kind of support the tip. Because again, these instruments are often curved, and besides just angling your hand back and lifting up, you can actually take a woodson or an object like you see on the left side of the video, the retractor, like a woodson or some type of retractor, to physically protect and also lift the bend of the curved object up and keep increasing the contact and stability of it as it's cutting forward on the bony edge. And that's a very useful tip control technique. Now, the key is that this is a spinning cutter, and like all spinning drills, irrigation is very important to A, flush out all the bone debris that's being created, and also B, to keep it cool and prevent overheating of the bone and the drill itself. So you always want to make sure to apply the irrigation and always make sure the tip remains wet. You can irrigate with a secondary irrigator. You can use the Dreal inline flow with a stopcock to address the amount of flow you're getting. But if it's getting hot you're not getting enough irrigation. If there's smoking, you're certainly not getting enough irrigation. And this is a safety factor too, because this grummus and material builds up in the cutting space that can bind, act as sort of a glue and sludge, and bring the dura in, which is obviously not good. So these are all things you can do, and not to mention just leaving behind bone material can sometimes lead to problems down the line as well. So good irrigation, good suction, flowing things out of the area, these are all very important parts of optimizing the thing. And so here you can see that, that looking at how you want to cut, the shielding of the Dreal drill allows you to slide on ligaments. As Bob was saying earlier, the Dreal devices come with shielding in different positions. They can shield such that you cut sideways. They're shielding like in the left part here. You see here, they're shielding on the bottom where it protects the underlying ligament and the nerve, and we cut the bone that way. And then if you want to work underneath, let's say you're cutting osteophytes underneath the thecal sac at the disc space, then it's shielded upwards like that too. So that's why Bob in an earlier slide had talked about you want to pick the shielding in the direction of the objects you want to protect. That's kind of an obvious statement, but again, it just requires a couple seconds of foresight so you can select the bits that you think you'll be using the most during a procedure and have those available for you instead of having to have the rep go run and get it and things like that. So thinking about what you need to do about where the compression is coming from. Is it coming from the facet osteophytes? We need to undercut those as we go across. Is it coming from disc osteophytes rising from below? Then we need the down shielding, the downward cutting with the top shielding. So these are all things you can think about and use the shielding to your advantage, but always again, maintaining irrigation whenever possible. Now, when in terms of lumbar decompression, there's all kinds of technique. As Bob mentioned, we published some of the very earliest papers in cadavers and then subsequent first clinical studies on the whole concept of working through a tube and achieving the minimally invasive version of the McCullough procedure, or the drill across ipsilateral bilateral decompression. And as we're working, obviously, there's the ipsilateral decompression where we're cutting towards us, and then of course the contralateral where we take the angle devices and we slip out the contralateral, as you can see here, foramen. And that's what these diagrams are really for. Here you can see the ipsilateral decompression. We're coming on our side, undercutting the facets and cleaning out our foramen in the lateral recess. And then once we get enough exposure and a small midline hemilaminotomy, we can go to the contralateral, slipping out the distal side, as you can see in this camera video where I'm slipping out the distal side with my tip as well. It's not the right tip, I'm just showing the angles. And then of course we can go from a far lateral to medial, like when you're doing a far lateral, this is like a true far lateral or endoscopic type approach. You can come in from the outside, cut down the, work down the facet joint here and work underneath and do an outside in Fram Anatomy. And then of course, as we talked about, you can do a top decompression to remove osteophytes that are compressing from the bottom disc space here. And then finally, there's the anterior approach where, let's say you're coming from an ACDF or coming from an ALIF, and you can take down osteophytes on the end plates. And you can also take down posterior facing osteophytes, like for example, in a cervical discectomy or an ALIF, where you can take back that marginal dorsal pointing osteophyte that's technically coming off the vertebral body. So in other words, the angles of the tools and the hand pieces can be selected, and the optimal tool can be selected for each of these various approaches and angles of approaches to optimize your cutting, if you will. And you can see that here on the MR X-ray, showing how we've come around the ipsilateral facet and we're taking down the superior articulating process stump of the ipsilateral or contralateral level, depending on which way you're working. So for some patients, the tools, the required decompression cannot be achieved using standard tools. And that's really what we're always saying. We're always constantly alternating between drills, if you will, and of course, keratins. So the problem with the drill is it requires a straight line of sight. So what do? We drill more keratin, curved keratins, so on and so forth. But by the time we're done, oftentimes we've removed a lot of the functional bone, the bone that's in the facet joint, for example, or we've retracted on the nerve roots too much. So by using curved devices that can reach around corners and go, again, into the foramina without having to come down straight and resect the entire facet joint, that allows us to preserve the key structures. That's where the curve design of the Dreal tool platform is very helpful, to pick the right tool so you can spare the functional joint and ligament and musculoligamental and bone complex, but also protect the nerves as well, but all the while essentially decompressing along the nerve, if you will, not having to constantly unroof the nerve, which leads to a lot of our structural stability long-term issues, as you know, even from a minimally invasive tubular approach, where we've always traditionally had problems with the line of sight of the ipsilateral facet complex, as you can see. And so that's really what it is right there. And that's why you can see in a big facet joint, we have to resect a lot of the facets just to even get to the external dorsal root ganglia of the nerve. But with a curved device, we can literally run it almost all the way out, slowly but surely. And you can even use fluoroscopy image guides to confirm that you're out that foramen. But the bottom line is, once we're now running effectively along the nerve all the way out here, as you can see, and cutting only the bone we need to ensure that the nerve root's free, because that's why we're there in the first place, to free the nerve root, not to resect the facet joint, especially in a lot of our decompression only patients, if you will. So that's what this slide is really meant to do. This study is done. So, okay, Dr. Khoo, Larry, you're saying you can preserve the facet joint. Prove it to me. Well, here we'll find that there's a 600 in a study that was done. We showed that with 5 levels were operated by 3 skilled surgeons, and we compared the CT of using standard tools, drills, and rongeurs versus the curved Dreal drill, just like I was just showing. We on average achieved a 163% higher increase using the Dreal drill, and the pars width, which is the risk of the pars fracture being created, the remaining laminar pars bone that is left and still available, is there's 24% or 1/4 less reduction using the Dreal drill. So as much, if not more, foraminal decompression across the length of the foramen while still sparing that biomechanically important bone of the pars, so we don't cause an iatrogenic pars fracture here and therefore induce potentially delayed spondylolisthesis fractures or pars defects in the days to come, which of course is the thing we're trying to do, because we're trying to reduce that 10 to 15% incidence of delayed coronal tilt or instability or listhesis that's often seen in older people after wide lumbar laminectomy, which is the reason many of us have to fuse those patients at that time or down the line. And so here is a video of the MIS Fram Anatomy, and what we see is, you can see, let's see if this runs here, but fundamentally, oh, well, actually, I guess it's not running. But I think what we're trying to show is that when we're using the Dreal drill, you can see that the shelf of overlying bone in this 18mm tube is well preserved, just like those videos we were running earlier. Whereas typically, you know, we always have to put in a bit of a shark bite to see and get the curved kerrison and get the curved curettes out that foramen using a standard straight jaw. So simply put, we help to solve with the curved Dreal devices the line of sight issues, which can only be previously solved by cutting more facet bone back, especially in a lumbar facet foraminal decompression or a cervical foraminal decompression as well in the back of the neck. So preserving the facet complex is one of the sweet spots and really the great benefits of using a curved curvature tool piece to achieve that decompression. Again, for those of us who've done ipsilateral approaches for bilateral decompression, it's always on our side that we have to cut more and more. The other side, we have the advantage of the angled approach, so we can cut underneath. But for this side, because we still come from top down, we still are always faced with the quandary of resecting more and more facet bone to ensure that our foramen is well decompressed. And in fact, unfortunately, with our long-term studies, our 2 5-year long-term lumbar decompression studies, it's always the ipsilateral side that we often don't adequately decompress, where often recurrent radiculopathy can occur in that area. So here's an example of the MIS TLIF decompression. It was used for undercutting the contralateral foramen and clearing the foramen without having, so in other words, a unilateral TLIF, obviously you take your facet, decompress it, but then you want to make sure the contralateral foramen is also open without having to go and resect the other facet and approach it. So if you only use a unitubular approach, again, this facilitates the undercutting of the contralateral foramina and clearing the other foramen. So in other words, you can use the same curve tool to achieve the drill across as well as the ipsilateral facet sparing Fram Anatomy, all with the same curve bit. You can see us working it there in the video. So what does that get you? Here's a post-op CT showing a very excellent, you see the trajectory of the drill across approach right there. And that's very typical. See how we can come all the way, take out the inner table of the spinous process, inner table of the contralateral lamina, get out the contralateral facet complex, but still sparing a good chunk of the functional facet joint. And the ipsilateral side here, the facet joint is intact, and it's allowed us to come around and work around without having to cut more than 50% of the facet joint, which we often have to do in these older hypertrophic facets to achieve neural decompression. Again, why are we there? We're there to achieve decompression. Here you can see the sagittal cuts showing that we've gotten out the foramen, we've opened up the disc herniation and the large framinal chronic synovial osteophyte cyst, and decompress it adequately to ensure good framinal decompression, which again is one of the sweet spots and one of the main advantages of using these Dreal type technologies in that area. So again, avoiding instability. Here's another example of us removing that marginal osteophyte. On this upper right panel, you can see there seems to be a calcified synovial cyst type complex coming directly off the facet capsule. You can see how that leads to a true foraminal, mid to far foraminal compression. Came down, is causing exiting nerve root pain at L4-5, foot pain over the dorsum. And then by removing the 4-5 osteophyte / calcified synovial cyst, the osteophyte's removed, and you can see it clearly gone on the post-op CT with a small hemilaminotomy and a preserved facet complex, and most importantly, the foraminal decompression easily achieved without having to cut out a huge portion of the L4-5 left facet. So that's a lot of examples of the typical kinds of decompressions and procedures that can be done in the lumbar spine with this tool. Ipsilateral decompression, contralateral decompression, all the while preserving the overlying bony structures. Underneath decompression, preserving and protecting the neural elements, always drilling down osteophytes coming off the disc complex, osteophytes and calcified synovial cyst coming off the facet complex. It's just a very elegant, anatomically correct, protecting the dura type device that is really great from that perspective. And I think it would be a great time if we could just take a little break and kind of fire off and hit some of the questions so I can stop talking for a second and see if anybody has anything they want to add from their experience or anything else that you feel would be a good thing to talk about. I think from Dr. Ying Chen, he said, any thoracic with thoracic disc herniation? Yes, we have. And in fact, there are some slides coming up in the slide deck where we're going to talk specifically, Dr. Chen, about that. So if you can bear with us a few minutes, I'm going to show you that. But it's a very good tool for calcified discs. And I will be the first to say, if done with the correct approach, because obviously you want to come in an oblique angle, like a costo-transverse or a transperpendicular approach. But because you can use the down-pushing, top-shielded device, you can protect the spinal cord and push down and slowly drill down and shave the lumbar, the thoracic osteophytes, and it's a very wonderful tool from that perspective. So no, it's a wonderful tool, and I'm going to show you a few slides specifically on that coming up. But you're right, that's the type of thinking you want to be using. Think about the limitations of our existing procedures, because we don't have what have we used for thoracic disc herniation? We take it like an osteotome and bang on it, right? That's never good. So this is a nice controlled tool that will protect the dura and let you push down and shave and sculpt and flatten the osteophytes and then dig a pit to do it more. So we'll see some slides of that in a few moments. So yeah, the next few slides are really about, for all the doctors and surgeons on the board, please throw it out, because I know I'm talking right now, but really all the reasons we like these tools, they're not magic. They help us solve problems that we have in real life. I mean, we've been doing I personally have been doing minimally invasive tubular lumbar decompressions now for 19 years. Like I mentioned, our first publication was in 2001 on the technique, and That was from work that we did from 1999 to 2000 through tubes and then smaller endoscopic type tubes over the years. But what we learned is that we have angle limitations, because at the end of the day, you're still working through a tube and you can't turn corners in a tube very easily. That's where these tools are very helpful. And Dr. Yang Chen just brought up another excellent example. We always have a tough time doing calcified discs because they're coming up from below and they're pushing on the spinal cord from below. But how do we push down on the bone, take off a large bony osteophyte without retracting the dura or injuring the spinal cord? And so working around angles and working in deep holes where we can't see, but with a controlled, powerful cutting tool is always the problems of all the surgical approaches. And so we've got some cervical applications back. I see your question from Matt, and I'm going to show that to you. And before I jump to that one, Dr. Byas, I think, from Panama, he was asking, how far lateral would you recommend as a limit on the lumbar spine? May I ask Dr. Byas, do you mean how far from medial to lateral would you go, or how far do you want to approach laterally? If you could clarify that question, Dr. Byas. Okay, please,
hello,
please.
Trevor, and hello, Dr. Khoo.
Yes,
Yeah, if we were doing like an over-the-top technique going through the ipsilateral all the way to the other side, how far lateral would you go on the contralateral side? What would be the margin to go?
Yes, sir. So, as you know, was that Dr. Mola or was that Dr. Byas that just asked that? Was that Dr. Byas?
Byas. It's Dr. Byas. Yeah, thank you very much.
Thank you, sir. So, as you know, when you're doing the drill across, that's the most disorienting thing about the procedure, especially when you're first starting to do it. And even now, like I've done thousands and I still get disoriented because I don't know how far across I am. So your question, I think, is really in two parts, right? One is when you're going out the contralateral foramen here, like how do you know how far you are? Because all you see is the nerve root and bone over it. And one of the general rules of thumb we still use to this day is I will oftentimes just keep the fluoroscopy in an AP position. And if I'm ever confused, I will just swing the fluoro in, like it's in AP. So I have the wig-wag of the fluoro. I move it out of the way and sitting to my right or left. And then if I'm confused, I just step back, bring the AP, and I shoot a fluoro. And that shows me how far out my tip is. So I used to stop, the answer is I used to stop sort of mid in the framing, but now, to be truthful, with the longer curved instruments that we have, I like to often go all the way out because you have to look, as you know, and I don't have to tell you that when you look at the facets, sometimes you have those big hypertrophic facets where the superior articulating process has really come quite a bit up into the frame and has closed it down. In those cases, you have to go all the way out because if not, you will not have fully decompressed the lateral superior articulating process, and there can often be still residual foraminal compression. So to your point, you have to go as far out as the SAP goes, simply put. Sometimes you don't, but you have to look at the preoperative axial and sagittal MRIs. So that's answer number one. Number two, anatomically, one of the visual landmarks we have always used is that as we're going out this nerve, once we see the swelling of the DRG, which is right here, as you see the nerve roots start to begin to get fat over the disc space, that's another visual cue that we know we've gone far enough because typically the DRG sits at or near the lateral edge of the SAP, and that's another visual use we have. But in honestly, what we've done over the years is every August, July, when new fellows start, we always drape in the fluoro, have the fluoro there because we work through tubes, we need to confirm level, and then we leave the fluoro in an AP position to know that we're far out enough for whatever bony pathology is and exists. And then nowadays, we'll show some slides in a little bit, you can take the Dreal and our drills in general, and you can navigate them as well. And that's another way you can know you're past the point of tip. Because as you know, I humbly put to you, I've had a lot of patients where I thought I did enough, I thought I went lateral enough, but at the end of the day, I wasn't lateral enough. And then the patient has residual radiculopathy or recurrent radiculopathy over some time, and I always kind of kick myself for not doing a good enough job. And that, in truth, is also the problem ipsilaterally, going around your own corner and making sure you have enough of that done as well. So that's why having curved devices and also having ways to check intraoperatively is important. I know sometimes you're like, I don't want to pull the fluoro in. This is a pain in the ass. But, you know, a couple minutes there is worth a whole lot of headaches later on of having to bring the patient back, or the patient still having symptoms, and you're trying to explain to them in clinic how maybe we didn't decompress as far as we could have, and so on and so forth. So I think that's I know that's not a simple answer, but that's what we've learned, myself humbly over the years. Sir. And Dr. Mola, also from Panama, did you have a separate question, sir?
No, I haven't a question. Thank you very much.
You're welcome, sir. Obviously. Thank you. Okay, great. Thank you so much, Bob. So coming back, I think someone was asking from Matt, could you explain the cervical application? So cervically, obviously, we can do Fram Anatomies from the back as well. And that's very similar to lumbar Fram Anatomies. You have to use you have to be very careful because it's obviously a much tighter area. But also from a standard ACDF, we have these type of devices that are shielded at the foot. And you can see that right here. They're foot shielded devices, and I'm holding one in my hand right now, if you can kind of see that, that are really optimally designed to come down, as you can see in this video, come down to this space, and then work around the corner to take apart those osteophytes that can often be very difficult. So, you know, how like the ACDF, we often will take those marginal osteophytes with a combination of, again, drilling and kerosining underneath the edge. But this is nice because it allows you to do a real angular cut, as you can see in the video where I'm demonstrating here with the side cutting device, to remove those osteophytes and make sure that the dura is completely decompressed without having to slide big kerosins and things under there. And here with there's a much longer upcutting version, and that can be used once you've created a partial cut of the osteophyte, and you can get another tool, and then you get the curved upcutting tool, and you can actually perform an undercutting corpectomy, or like a much longer partial posterior corpectomy to decompress the cervical spinal cord or the thecal sac in an ALIF. And so that's the cervical application. So standard Fram Anatomy using the upcutting bits, and then undercutting osteophytes of the dorsal disc space, and even some of the bone in cases like that, as you can see in this graphic right here as well. So these are all techniques that can be done with that, and I'll show you some of that. So this concept of using it to remove anterior bone osteophytes here at this space right here is something that, for example, Dr. Ashkenazi, Ali, and Dr. Geyer and Harrell, and some of the other people have used to remove osteophytes that you would have otherwise had to do a full corpectomy to remove. And so these are 30 patients where they did just that. They were able to gain access to osteophytes in adjacent vertebrae, eliminating the need to do a full corpectomy, if you will. So from one ACDF or one corpectomy approach, you can do the next level's ACDF decompression as well. And you can see the outcomes of that, the fact that the decompression was adequate, was good, and was effective in relieving the radicular symptoms. Here's an example. You can see on the MRI, 69-year-old male with severe myelopathy from what's called the segmental OPLL type thickening and osteophytes. And you can see what they did was they did a one-level corpectomy, which means 2, 3, 4, 5, a C5 corpectomy. And from the C5 corpectomy, they reached around and they decompressed all the elements behind the C6 body and down to that. And then they did an ACDF underneath the C6 body. So they were able to undercut it and preserve the C6 body and not have to do a full C6 corpectomy. In other words, they got all the bony compression, but managed to save a good portion of the load-bearing portion of the C6 vertebral body and allow you to do a short corpectomy cage and an ACDF cage with 3-point fixation, which obviously biomechanically is much better than a long corpectomy cage in terms of rotation, inflection, extension, stability. So you can see the arrow pointing out where they had reached under and cut out that central calcified PLL ligament, and how they did a very nice job with that. So multi-level compression, saving bony attachment points, saving vertebral bodies. That's another benefit of the extended cervical applications of these tools. And there you can see an intraoperative video or a lateral fluoroscopy showing how he's reached the curved tool through the corpectomy defect right here, and we're undercutting the posterior aspect of the cervical C6 vertebral body. But you see, we're reaching here all the way up to halfway up the vertebral body. So again, you know, sparing the knee. Notice people say, how do you decompress right behind the vertebral body if the PLL is calcified without taking the vertebral body? And this is an alternative right there as well. So again, another case report, oops, sorry. Another case report, again, you see 2, 3, 4, 5. Again, from there, you see these large osteophytes coming off. And then this is much more of a standard ACDF approach. We're always reaching to take down these osteophytes above and below. And again, that tool we mentioned allows you to side cut safely and effectively remove all that osteophyte pre and post-operatively. You see the osteophyte's been nicely resected from that perspective. Oh, you're welcome, Matt. Thank you. And so here's another uncinate resection of Fram Anatomy in a standard ACDF. You can see here, not only can you undercut those bony edge osteophytes, you can also do it kind of sideways and reach into the frame, because sometimes you have these large osteophytes coming off the anterior edge of the vertebral body, pushing in and compressing on the nerves right there in that corner, or like an ACDF right there in that corner in what we would call the proximal frame or lateral recess. And again, here you can see on the post-operative CT, they've resected with the side cutting tool, they've resected a portion of the lateral uncus to again ensure that there's no residual compression of the exiting nerve root, which again is something that in a very narrow slot ACDF that we sometimes leave behind, if you will, and leave behind residual compression. And that's where you can see 20 patient case series using, you know, we always say we do a central spinal cord decompression, we do bilateral Fram Anatomies. So this, again, it's an elegant Fram Anatomy tool that can be used to open up those spaces. And so that's really the cervical compressions. And another thing is with the down cutting, top shielded device, you can use it obviously to reach around other corners. For example, where's another case that we often have a difficult time reaching to the other side, reaching underneath the dura and the posterior longitudinal ligament? A TLIF. So here you can use the tool now to scrape off the subchondral cartilage and delaminating that cartilage, and thereby being able to take out the cartilage and the attached disc out. So a unique solution to prepare the end plates without big curettes and gouges to preserve the underlying subchondral bone, but yet removing the cartilage and the disc without gouging into it, and also allowing you to reach much further to the contralateral space to slowly, essentially shave off and delaminate the subchondral cartilage far beyond what you can often get with just a typical short curette or curved curette. And this is an example. Here you see the Dreal device. And then another thing is with the curettes and things like, yes, you can get the curve, but you have to keep putting the tools in and out. And often through a narrow TLIF Cambin's triangle, as you're doing that, as we're reaching in and out of Cambin's triangle, you can traumatize, obviously, the exiting nerve root. Because of that, this tool allows you to simply pass into Cambin's triangle once and then elegantly simply reach across and shave and delaminate the subchondral end plate and take out the disc and minimize the number of passes you have to do, and thereby decreasing your risk of radicular injury to the dorsal root ganglion. And that's example of the Dreal, 10 passes with 41 passes of curved curettes, pituitaries, so on and so forth to achieve that. And you can see you get a much more consistent, controlled, even preparation of the end plate here versus this kind of gougy pockets here, pockets there type of passes with far more risk of traumatizing the DRG with multiple passes, while ironically achieving a less thorough, less consistent end plate prep here as well. So that's a very good example of that. And here's just some cases to show that, you know, we're not just whistling Dixie, we can actually get fusions. And there you can see the bone here and the bone there and the bone growth around the cage, meaning that the subchondral end plate and disc were removed in that area, and we can make sure that it's fully decompressed and we can get the postoperative bony ingrowth that we all want to see. Again, nothing radically new, but just another elegant tool. While you're doing the TLIF, you can use it to decompress the contralateral frame, and you can use it to now decompress or decorticate, I should say, the cartilaginous end plates. And these are all just Again, tools that help us solve intraoperative problems. How do you work around underneath the dura to get the contralateral end plate? Well, now you have a Dreal cutting tool that you have nice controlled passages without traumatizing Cameron's triangle excessively. And you can see that here at the end of the case report. So again, part of Dr. Ashkenazi's little work, it was he looked at the cost changes of using just this suite of tools with our friends Jean-Charles Lewec and Tyler Koski. And you can see it right there that with the Dreal, it was a little bit faster because it allowed us to decorticate, and less passes equals less time. And I had overall decreased complications and readmissions for radiculopathy, radiculitis, and things like that. And you can see the overall benefit in the US and the cost reductions overall because of that. So again, this is something we've always said, minimally invasive techniques and TLIFs lead to cost savings in terms of damage to soft tissue. It leads to less infections, it leads to less blood loss, shorter operating time, shorter length of stays. And the Dreal tool is yet another tool in our armamentarium of less invasive surgery to again achieve additional reductions in costs and complication rate as well. And so this is also comes back to Dr. Ying Chen's question earlier. What about thoracic discectomy with or without fusion? Because a lot of times this is the spinal cord. In the thoracic disc, we can't retract the spinal cord, unlike you can in a TLIF. You can retract the fecal sac a little bit with a nerve root retractor, right? But you can't do that in a thoracic disc because that's a spinal cord. Spinal cord thoracically in the thoracic portion is highly intolerant to retraction. You can get loss of motor verb potentials, you get hemiparesis, you get Brown-Séquard syndrome. These are all the dreaded complications of a thoracic disc. So because of that, with the Dreal tool, we can now safely reach underneath the spinal cord with the curved down pushing tool that we were showing earlier, and then cut down, push down the osteophytes, push down the calcified, shave the calcified discs with the shielding of this against the dura, and therefore do a gradual controlled resection of the disc, and then get into the inner body space, if you will, and resect the disc again in a down pushing controlled fashion without you having to put big tools down there to prepare the inner body space. So again, you definitely, Dr. Ying Chen, can use this tool to achieve an excellent, safe, slow, but safe decompression of a calcified disc fragment. And of course, prepare the inner body space if you so choose to do a fusion as well at the thoracic disc space. And here you can see the pre and the post MRI report showing that. And again, this has been reported using safe thoracic discectomies, same authors, Dr. Ashkenazi, Dr. Butler, Rick Geyer, Tyler Koski. And you can see that that this can be achieved with a unilateral device approach, safe neurological decompression from partially calcified discs that are not too exophytic. Obviously, big, huge exophytic calcified discs should, I'll be the first to say, it should be approached from an anterior approach. But the paracentral, not so mushroomed, partially calcified disc can still be approached from a costotransverse, transpedicular far lateral approach with this tool safely, and you can decompress and gradually work the calcified disc into a hole safely with these tools as well. And that's what this paper fundamentally showed. They had 12 patients with posterior thoracic discectomies, and these were all safely done, and showing that it's not only safe, feasible, but it's also very safe. And then some other extended things that we may not think of normally. For those of you who do anterior, you can also, a lot of times we're always, these are deep holes, and we often have a tough time getting to posterior osteophytes, especially the ones that come off the posterior edge and knuckle into the fecal sac or the proximal foramen. And just like the ACDF, where we can use the tools, we can also use these same tools to resect with the curve, the same tool that we're doing that partial corpectomy with. We can use the same tool to reach around and ensure that the osteophyte reaching posteriorly into the foramen, as you can see here, is also resected. Here you can see multiple level ALIF with the foramen fully decompressed at multiple levels, using this to resect the dorsal marginal osteophytes coming off the vertebral body to also allow you to put the cage further back. because you're resecting the osteophyte. Because this is a procedure we've traditionally done with osteotomes, bam, 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 bam. But now that's always a little scary, taking an osteotome in a deep hole and hitting it directly at the dorsal root ganglion. So here you can do it with a control tool, shave down, and get the same elegant posterior osteophyte end plate preparation without having to use osteotomes and protect the nerve roots. And you can see that there. So in summary, it's an excellent tool. There's a bunch of shapes. There's a bunch of different applications. There's a host, a wide variety of procedures where it can benefit you. And we all know as surgeons where we need help, at least if you're honest. I always say at some point you just say, damned be my ego, you know, I just need help. I need help because I've been doing this for 15 years and I still can't get around certain corners. And that's where the Dreal Carevature platform provides yet another tool to help solve those simple anatomical problems of working around corners and protecting the nerve roots along the way and minimizing the need to take too much load-bearing biomechanically important bone and also therefore decreasing the chance of postoperative instability. Now, going back to Dr. Mola and Dr. Byas's statements about how do you know if you've gone far enough? How do you know if you've done enough? This is where I would humbly put to you that, again, checking is the most important thing. And so obviously I just mentioned using fluoro, but now in the modern day, we have navigation. And so clearly you can put the short tracking devices of a brain lab tool or this is a Medtronic stealth station tool, but all these navigation stations have some type of tracking device that you can see clamp onto the handpiece of this and therefore know where and register the tip of your tool in the registration platform that all these navigation devices have, especially overseas. You can use this to Brain Lab, Stryker, and the Medtronic stations. They can all be used to register the tool to, you know, it won't give you a graphic of the whole tool, but it'll certainly let you know where the tip of it is. And then you can use that. For example, again, Dr. Yang Chen, you can see we'll be using it for calcified disc herniation here. And Ron Harrell over in Israel used it to resect that from a far lateral costotransverse approach. And you can see that's the transpedicular costotransverse drilling he did with the drill. And then he used a navigated drill to gradually create a cavity, if you will, and then doing a standard thoracic discectomy using the curved drill to, again, slide under the dura, protect the dura, pushing downwards away from it in a costotransverse or transpedicular type far lateral approach. And that's, I think, what you want to see. But the key is this lets you know where you are relative to the dura. This technology of tracking the tip can also let you know where in the framing you are. And to Dr. Mola and Dr. Byas's question you guys were asking, this way you'll know you're out the contralateral framing, you're past the SAP, you're good. And also if there's a very discrete osteophyte like that case I showed earlier with that calcified synovial disc, this will also let you know you're right there. So that's why tracking these tips is obviously something that we do. And it's something that we're probably going to do more and more of as we go forward, because at the end of the day, you know, with experience, you get better and better of kind of knowing where you are. But this is just a really nice way of using all the technology that we have available. It's just to make sure we do the best job every time. And, you know, I'll be the first to say that my ego and my arrogance and my rushing has led me to problems in the past where I thought I was somewhere. And then on the post-op CT or the MRI, I realized, oh my gosh, I wasn't nearly as far, or I missed that osteophyte. So this is just a nice way of tracking the space to let you know that you've achieved all that. So I think that's a lot of kind of the extended applications and a lot of the navigation type check type technologies that we have that can be integrated to the Dreal Carevature platform. I know we have a bunch of surgeons from Brazil, and I think according to the list here, we've got some of our friends out there from Georgia and Florida, Dr. James. Hey, Stephen, it's been a while. But if y'all have anything y'all want to talk about, maybe even some, not so much questions, but even like some of your own experiences, if you've had the pleasure of using this technology or other decompression technologies. Like I think I remember, Stephen, you used to use Baxano quite a bit in the past, and maybe some of your experiences and limitations, both in cervical, lumbar, thoracic decompression that you want to rap about. I don't know, with all this coronavirus isolation, we're all just sitting around in our offices in our homes, just not doing much. So might as well rap with you guys, because sure as hell my kids don't want to talk to me. So Go ahead.
Hey, Larry, can you hear me?
Yes, sir. Loud and clear. How you doing?
Yeah, Steve James here. Hey, good, good. Hey, I was just wondering, you get into a lumbar case, are you pretty accurate with what drills you need to start with that you're going to end the case with? Or are you opening one drill, then going to another drill and so forth to get the job done?
Honest answer, Steve, when I first started, I sucked at that because I often think, because you're good with the straight drill and the Kerrisons for certain things. And then you're kind of working and you're like, hey, shit, I'm coming at this particular lumbar space at this certain angle. And I'm having a problem kind of going up and to the left, right? Like in a frame, depending on what side you're coming from, right? And sometimes you realize that I need the side cutting one or I need the up cutting one. And so, yeah, when we first started, there were cases where I used 2 or 3 different pieces in the same case, which obviously from a cost perspective can kind of piss off your OR managers, make the reps real happy, kind of piss off your OR managers a little bit. So what I've learned is that it's like everything else in life, I've kind of begun to create kind of a stereotype list of procedures, and I creating a stereotype list of tools I need for that. Because, obviously I could open everything and do like the most perfect job every time. But I've realized for my drill across, for example, lumbar Fram Anatomies, because you were with us in Boxano, you remember like we'd like do 2 framing right from one hole. Remember that contralaterally? Remember that, Steve? And we
Right.
yeah. So I'm picking the tools now, the long bayoneted curve upcutting ones that will allow me to get contralaterally the 2 framing up there. And then I can use that same tool, flip it around and do my 2 proximal framing here. And so obviously I could use, like, for example, the side cutting tool to do my laminectomy a little bit here. But in truth, because I have to open the standard drill driver, the motor anyway, I have the straight bit for that. So I'm just doing a little bit more laminotomy and stuff with the drill bit. So that way I only have to open one. And if not, sometimes I'll use the down cutting one in a calcified osteophytic disc so that I can see on the CAT scans or the MRIs before I'm like, oh, there's a big old osteophytic ridge off that disc. So I'll prepare to have the curved up cutter, the bayoneted curved up cutter, and the bayoneted curved down cutter. And I'll know those are the 2 I want. Yes, sir. It says, Pat. Hi, Pat. Could there be application for skull-based pituitary case? I've seen interest in drill for these procedures. Thank you. The answer is yes, because curved, it goes back to that statement of when do we need tools? As a neurosurgeon, there are plenty of instances in the head, particularly here in the skull base and here where there's long endoscopic approaches to there. A lot of times when we're trying to drill out portions of the sphenoid sinus, of getting a larger resection of the vomer and things like that from a standard classical pituitary sphenoidal approach. There has been a whole host of technologies introduced by the ENT drilling companies to help us with that. But some of these side cutting tools and things like that for standard open, mini open sphenoid approaches may very well be useful. The curved approaches to undercut the sphenoid sinus, for sometimes the sinus ostia are very small. We can use them to open and resect the sinus ostia. Again, it's very nice because traditionally we've done this with Kerrisons. We've done this with just cutting a lot of bone out and just to get a bigger hole. But having this, again, is particularly helpful at preserving stability of the nasal septum, for example, and things like that. So I'm not a skull-based surgeon anymore, but I still work with, in my hospital right here is the House Ear Institute, and they're one of the premier skull-based institutes in the world. I work with them every day, and they've leaned over and looked and thought about that. And so certainly there's a great interest in that area, and I think it's the kind of thing where you just have to go to the skull-based surgeon, lay out all the tools there on the table, and say which ones do you think will help you. And I think that's what Dr. Leckenbrink, Dr. Slattery, who are 2 big skull-based surgeons here in the House Ear Institute, have looked at. And so, yeah, I think there's a lot of potential interest for this for skull-based applications for neuro and ENT skull-based surgeons. But I think you'll have to, again, because I'm not I still do some brain surgery, but I'm not a regular skull-based surgeon. I think you just have to lay it out, all the tools out, and let them figure out what they can use. And it'll be just like what I talked about, it'll be a feed-forward learning process. Our Dr. Oh, Yossi asked, am I using Dreal in instrumented spinal cases as well? I have, particularly the TLIF, because in a unilateral uniportal TLIF, we still, just like everyone else, have the issue of how do you decompress the contralateral side? And again, just like I just showed, and we've all showed, we all use the Dreal devices to, you don't necessarily need to resect your facet. Obviously, you're going to take your whole facet to do the TLIF, but you can use it to do the contralateral decompression so you don't have to do a wide bilateral exposure. So from that perspective, it's wonderful. And again, you can use the down cutting tools to prepare the contralateral end plate, which again is a limitation of a uniportal unilateral approach to a TLIF. Because, even with curettes and things, besides, like I said, not gouging the end plates, one of the things is we just can't reach to that much area. So that's why TLIF end plate preparation can range anywhere from 30 to 75%. But having a controlled tool to optimize end plate preparation, in addition to contralateral decompression, are two of the areas in a TLIF or instrumented fusion that the Dreal devices can be of great benefit to for decompression and for end plate preparation for fusion as well. So certainly I think both of those are quite reasonable. And on a practical level, to speak to what Dr. James was talking about, Stephen was talking about the DRG, or the amount of money that the hospital gets for instrumented cases, is certainly much higher than for a decompression. So you can use what I'm trying to say is you can use one or two different types of devices in a fusion with far more impunity. In other words, you don't have to stress about the cost as much than a decompression. So I think that's why using Dreal devices in instrumented cases is still very beneficial. Yeah, exactly. Especially at L5S1. L5S1 TLIFs continue to be one of the harder things we do because it's just a big end plate. It's hard to reach across to prepare the end plate. It's hard to reach across to do the contralateral decompression. So those are areas where the curved long reach devices are particularly useful and make us, help us solve the length and angle issues. Yep.
Well, great. It looks like questions are kind of slowing down a little bit. Dr. Q, we'll just do a little bit of a close here and give anyone a little bit more time. I see some are dropping off, but I want to thank you for your time. I know you had a busy day in clinic, and I appreciate you jumping on. So I know you got my text, and I said I'm getting started here. I typically only go 5 minutes, so I appreciate you getting on when you did. And I know you've been really busy with the COVID thing, so appreciate you and all of the surgeons and the medical personnel out there that are working long hours. Very much appreciated.
I pray that all you guys out there, Dr. Byas, Dr. Mola, Stephen, everyone out there, Dr. Chen, I pray that all you guys are hanging in there, because this coronavirus thing is, whoa, it's it's been something. We're seeing strokes, neuropathies, all these things that, coagulopathies, DVTs, it's crazy. Pulmonary embolisms, infarctions. The point is that, this whole thing's reminded us what exactly we are, which are doctors in the end. And so I hope everyone fares well and does good work. And so hopefully we'll all get through this. But yeah, I know it's tough for everybody right now.
Well, thank you, Larry. And thanks, Cindy, for all your coordination, Dennis, Yossi, and all of you that have attended. We couldn't do this without all of you. We appreciate our distributor partners. Again, you're our hands, our feet, our eyes, and so we appreciate the partnership with all of you. Thank you for encouraging surgeon colleagues to attend as well. So, and our brothers and sisters in Brazil and Panama, thank you for your attendance. And those of you that are getting ready to get up in a few hours, thank you, Yossi. So everyone have a great evening. Be safe.